Well, thank you so much. It's a great pleasure and honor to be here at Oxford University. I studied in the Gorgas course in tropical medicine in Peru about 10 years ago, and one of my professors was David Worrell. So, Sir David Worrell is such a eminent figure in the world of tropical medicine. So it's a great honor to be here. So I practice medicine in New York City, and I wanted to just give some updates about how we are approaching the travel medicine issues in the era of many of the recent outbreaks, in particular with the Zika virus outbreak. The concept of travel medicine has been around a long time, but I think the formal guidelines that were published in 2006 are helpful to think about the way that we approach travel medicine for travelers who are about to go abroad and those who are return travelers. And it certainly involves a lot of concepts within infectious disease, but it's much broader than that. And physiology of high altitude sickness is certainly one of the topics that comes up. But the things that we're focusing on for pre-travel evaluation typically entail an assessment of the overall health of the traveler and any particular immunosuppressive conditions. Certainly pregnancy is now a major issue that has come up with the Zika virus outbreak. We try to be very specific in terms of itinerary because there are many countries in which, for example, in Peru, we'll have highlands and we'll have jungle and we'll have desert, and there's different types of risks associated with each region. A lot of our focus is on pre-travel vaccinations and insect prevention measures. We think a lot about malaria because it's certainly a very preventable illness as well. Travelers' diarrhea, a very common cause of illness for travelers when they are returning, but also when they are abroad. So we think about different ways of educating travelers before they go. In the post-travel evaluation, we're trying to think about a couple of different possibilities. It certainly could be something exotic like malaria, dengue, typhoid, but we always want to keep in mind the common causes of fever in a local destination. So for us in New York City right now, it's influenza season. We're seeing a lot of influenza. And it's important for us to keep that in mind as we evaluate travelers, that it could be something unrelated to their trip. So incubation periods have gotten a lot of attention recently with the Zika virus outbreak because it tends to be a very short incubation period for most hosts. It's similar to dengue in that sense. So dengue is an illness that typically will present within 2 to 7 days of a mosquito bite. And many travelers are ill while they're still abroad. With many types of malaria, falciparum malaria, that can be a longer period, usually around 10 days, or even several months if it's a non-falciparum type of malaria. For typhoid, we're usually looking at 1 to 3 weeks, but hepatitis A, for example, can be over a month of incubation before patients start to develop their symptoms. So those incubation periods in overlapping clinical syndromes can be helpful for us when we're thinking about these different presentations of undifferentiated fever, for example. So there's been numerous outbreak events over the last decade. If we think back to SARS of 2003, but also recent outbreaks of polio, dengue, chikungunya in the Americas is another event that had not previously been seen. And the rapidity of the spread of chikungunya has been a kind of a model for how Zika virus has also spread. The Middle Eastern Respiratory Syndrome has also been an important novel coronavirus. The Ebola outbreak as well. I'll talk a little bit about that. We're monitoring as well some events such as avian influenza, since it typically is something that's associated with direct contact with poultry, but we're always worried about the possibility of potential human-to-human spread. And then this is the current map for Zika virus-affected countries, but I'll talk about that in some more detail. I think SARS in 2003 was a real demonstration of how quickly diseases could move across international borders in the era of airline travel. So this was initially a novel coronavirus that was seen in southern China, and then as a very well-described outbreak in a hotel in Hong Kong that led to several travelers returning to North America and several healthcare worker exposures as well. So that was another concept of how we approach infection control in some of these novel zoonotic infections. MERS was a similar coronavirus. It's also still under study. The initial outbreak was in the Middle East, but then we subsequently saw several countries affected again through international travel. There was a second epidemic in Korea that you'll recall was quite significant as well, and also involved numerous healthcare associated exposures. So that's informed a lot of the way that we're approaching infection control. As I mentioned, influenza comes as both seasonal and pandemic forms, and 2009 was another major event in the field of influenza. A lot of my colleagues at Mount Sinai are involved in studying influenza virus, and they were very interested in the similarities between 2009 and potential similarities with the 1912 epidemic. And some of them were able to reconstruct some of those earlier pandemic viruses to look at the pathogenicity of these viruses. But the current H7N9 avian influenza outbreaks have mainly been associated with direct contact with poultry and not so much with human-to-human spread. So chikungunya was a virus that was really not seen outside of a few countries in Africa and later Southern Europe. But because the vectors are present in so many other parts of the world, Aedes aegypti and Aedes albopictus, we started to see outbreaks in the Americas and the Caribbean, and that quickly led to a very, very large epidemic. So these were back from the fall of 2015. Our numbers were around 78,000 locally acquired cases of chikungunya in the Caribbean and the Americas. And that was over a time period of about a year, and then we had seen over 658,000 cases. So it's really quite widespread throughout the Americas currently. The Ebola outbreak, as you'll recall, that initially started in West Africa in the spring of 2014, was thought initially that it was going to be a short-lived epidemic, as most Ebola outbreaks are. But this was something unprecedented. It was really a quite rapid spread throughout West Africa, and then subsequently throughout other countries, including the United States, with at least 2 healthcare-associated exposures. So again, a different approach to the way we had to face infection control measures. These are some of the signs that the CDC was posting, and we were considering travelers returning from Ebola-affected countries having to think about a different level of precautions that we were used to, certainly in New York City. So Zika virus in the Americas is another phenomena that is part of these epizootic infections that are transmitted by vectors such as Aedes aegypti. It's a flavivirus, so it was initially described in 1947 in Uganda, and it was associated mainly with rhesus macaques. In the 50s, we started to see some human cases. It's considered a milder disease than dengue or chikungunya. It typically causes some joint aches, conjunctivitis, and rash. But it spread fairly quickly to other countries in Polynesia and New Caledonia. The first time it was reported in Brazil was in 2015 in May. It's now widespread throughout South America and the Caribbean, and as you'll see from the websites in the WHO, they're constantly updating countries in which it's confirmed to be present. It is transmitted by Aedes aegypti and Aedes albopictus mosquitoes. The mosquito vector is the same one that transmits dengue and chikungunya, so distinguishing between these illnesses can also be a challenge. So the causal link to microcephaly in infants, mothers who are affected during pregnancy, is becoming stronger and stronger in terms of the level of evidence. And I'll go through some of the recent publications on that as well. And we are seeing documented sexual transmission occurring as well in the United States as well as in some other countries. So the clinical disease with Zika tends to be a short incubation illness and a short period of viremia. So typically our return travelers are presenting within 2 to 4 weeks of their illness, of their travel, and they're typically going to have an illness that lasts from 3 to 7 days. The period of viremia, where we can detect the virus with PCRs in the blood, is also short, and it's probably around 2 to 4 weeks. The typical symptoms are shown here. So here's a published case of Zika virus rash, where you can see some involvement of the chest and sometimes the palms. Myalgias and conjunctivitis can be useful clues as well. But in some epidemiologic studies of the outbreaks in Polynesia, we were seeing quite high rates of asymptomatic infection as well. So that's been a challenge as we're assessing some of our returned pregnant women as well. So it's just a bit of a map and a timeline of where the cases were initially described here in Uganda in 1947 among primates mainly. Later, here in Yap Island was a very large outbreak, and that has led to some interesting epidemiologic understanding of the virus. Here in Tahiti, there are some descriptions, in particular of the issue of potential sexual transmission with detection of the virus in semen in a patient who had some hematospermia. And then later, the outbreak that has spread to the Americas, initially in northeastern Brazil, and then throughout most of the South American continent and the Caribbean. So again, this is some of the areas of active transmission. If you go to this is our Center for Disease Control's website. They have an interactive map that gives pretty up-to-date statistics on the outbreak. This is the epidemiologic curve from the WHO, and they're also keeping track of individual countries as well as by region. It's a really large epidemic, and it's really quickly spread throughout many areas where we have these mosquitoes. So the association between Zika virus and microcephaly was initially an epidemiologic association and observation in that we had a 20-fold increase in Brazil concurrent with the Zika virus outbreak. The pathologic associations that have been made with detection of the virus in fetal brain tissue, PCR, immunohistochemistry, and electron microscopy were described in a New England Journal paper that was published fairly recently in February. So the authors here are actually from Slovenia, and they had a return traveler who had spent time in Brazil during her pregnancy. During the course of the pregnancy, it was noted on ultrasound that the developing fetus had multiple microcalcifications, indicating inflammation and necrosis in the brain, as well as a very, very small brain. So microcephaly is defined as being below the 3rd percentile of the average size of an infant for gestational weight and age. And this particular case was a developing baby that was less than that 3rd percentile. So in the end, it was determined that the woman wanted to terminate her pregnancy. She agreed for autopsy and further studies, and they were able to observe numerous areas of inflammation in the developing brain, some atrophy of the ventricles. On the histopathology, what they're seeing are typical cytopathic changes associated with viral infection, as well as areas where they can confirm presence of Zika virus by immunohistochemistry, as well as typical cytopathic changes. The electron micrographs that are from this study are also showing these. They're basically virions. They're virus-like particles that are found in the tissue of the brain, and these are consistent with a flavivirus. They were able to recover the virus through molecular methods as well from this tissue. So it just led to further mounting evidence in terms of the virus's role in microcephaly. They did some fairly elegant genetic analysis of the virus and compared it to some of the other strains of the virus that have been described. This one genetically is fairly close to the one in French Polynesia. So the outbreak sort of timeline correlates with that as well. So the issues with sexual transmission have been ones that have come to light, especially in the last few months. But were previously described in the outbreak in Tahiti. As I was mentioning, there was a case where a man had hematospermia, and the virus was recovered during that period from the semen. In the United States, there are currently 14 cases under investigation. 2 of them have been laboratory-confirmed cases in pregnant women who had not traveled outside of the United States, but who had a sexual partner who had been in areas of Zika virus transmission. That male partner, had a febrile illness with conjunctivitis and other symptoms consistent with Zika virus, and was subsequently confirmed by serology in at least one of the cases to be positive for Zika. A couple of these cases were excluded based on additional information, and there are 4 probable cases with 6 under investigation. So, this is obviously an additional cause for concern in our not just return traveler population in terms of pregnant women, but also their sexual partners and the ways that we're going to look at preventing this issue. Some of the concern has been the uncertainty. There's certainly a lot more that's not known about Zika virus than is known at this point. And I think a lot of our public health experts are trying to determine what is the appropriate period of time for which we can feel reassured that, let's say, a returned traveler who's coming back after visiting the Caribbean or South America can feel like it's unlikely for them to transmit the virus to their partner. And that's led to some recommendations from our Center for Disease Control that, at least for pregnant women, if their partner has traveled to a region affected by Zika, they either abstain from sex or use a condom throughout the rest of their pregnancy. So I think there's still a lot of uncertainty there about what's the right thing to do. It seems like all the cases that have been described so far have been in men who are symptomatic. So those that have the typical conjunctivitis, rash, fever are probably at highest risk of transmission of the virus. There are some experts that are saying probably it's a reasonable period of time to wait 6 to 8 weeks after a travel exposure before those patients, let's say, try to get pregnant. Because that's a lot of the questions that we're getting from our either return travelers or couples who are thinking about starting a family and are having some recent travel to some of the affected areas. So it'll be interesting to see how that part of this story develops as well. Okay, here's a couple of pictures of the Aedes aegypti and Aedes albopictus mosquitoes. So in the United States, we are a country that's endemic for Aedes aegypti, mainly in the southern part of the United States. So this is the south coast, and these mosquitoes have been associated with some local cases of dengue. So in Key West, we've had a few. Key West is not even on this map, actually. It's south of Florida, very close to Cuba. And we've had a few cases of locally transmitted dengue. But it tends to be a very rare event, and that's mainly because it's a situation where most of our population is living in quarters where they have sealed windows, air conditioning. They're not living in close contact with, let's say, collected water. And that's been one of the issues in many of the countries like Brazil, where people tend to collect rainwater if they don't have access to regular drinking water. And that's led to a breeding ground for a lot of these mosquitoes. So Aedes aegypti is an aggressive biter. It's a daytime biter. It's different than the Plasmodium falciparum transmitting mosquitoes with Anopheles. Anopheles tends to be a nighttime feeder, so we can have some precautions such as nighttime mosquito nets that help prevent transmission. With Aedes aegypti, these are urban mosquitoes that live around humans, and a lot of the control measures have to do with trying to prevent them from having safe breeding grounds with standing water. So Aedes albopictus is a related mosquito, and it's thought to be a less efficient vector for these flaviviruses, for dengue, for chikungunya, and for Zika. But it is one that's of concern, and that's one that's present in a very much larger region of the United States. So it's also led to some of the concern about our upcoming summer months when we tend to have more mosquito activity present. So those mosquito vectors, as I was mentioning, are transmitting other illnesses. And I wanted to just talk about some of those others because we're thinking about overlapping clinical syndromes. So this was a patient with severe muscle aches, drenching sweats, elevated liver enzymes to 86 and 92, so normally those are less than 40, and a reduced platelet count. And this was a patient who had recently traveled to India and presented with this faint rash that sometimes if you press on the rash of dengue like this, you'll sometimes see an impression for a few seconds. That can be a bit of a clinical clue. But this is dengue virus presentation, and it can be very, very similar to what we see with Zika. The main distinguishing points here, I think, are certainly patients with severe dengue can present with shock, and that's something that's going to be important to recognize because our clinical management of that is different than what we typically do with patients with Zika virus. There are recommendations to avoid non-steroidal anti-inflammatories because of the potential for its effect on bleeding and platelets. So that's impacted some of our decisions about managing Zika as well. So dengue is typically, as I was mentioning, a short incubation period illness, 2 to 7 days. It's often associated with these quite severe body aches, so the degree of the myalgias is perhaps more severe than what we see with chikungunya or with Zika. Although the chikungunya, which is an overlapping clinical illness, the patients we've seen returning with that illness typically have very severe joint pains, and it's very small joints, typically their fingers or their knuckles, and those joint pains can actually last quite a long time. So that's been the concerning issue with chikungunya. Thrombocytopenia is certainly a big concern with those with dengue, and that can be associated with hemorrhagic syndromes in those that are presenting sometimes with multiple infections with dengue. Okay, I wanted to talk about some other overlapping clinical syndromes and things that we need to think about when we're thinking about Zika virus, because fever can be such a nonspecific symptom. So as an example, here's a 45-year-old United Nations employee who returned from a 6-week visit to his home country of Nigeria. And he had fevers along with diarrhea, headache, dark urine, renal failure, severe anemia, and icterus, which you can see on his clinical exam here. So that was not an evidence of liver injury. In fact, it was a major hemolysis episode that was happening because all of these infected cells had the rings of Plasmodium falciparum. All right, so this is malaria in its worst type. So falciparum malaria can be associated with the renal failure, with the end organ damage. We'll sometimes also see patients with falciparum with very, very high parasitemias, and certainly that's another indication for more aggressive therapy. There's just some more examples of the smears. Sometimes you'll see very high levels of these parasites infecting the red cells. We can find a banana-shaped gametocyte that can also put us in the direction of falciparum versus other types of malaria. Here's another contrasting case. So this is a patient who was working with MSF, with Doctors Without Borders, and she spent about 11 months in the Democratic Republic of Congo. And while she was there, she had malaria several times. She was treated with artesunates and opted not for prophylaxis, but artesunates are very effective therapy for that, so each time she felt better. When she returned to the United States, she went through a parasite screening that is part of the return protocol for MSF workers and volunteers, and her malaria screen was negative at that time. But a couple of weeks later, she started having again some of these fevers, chills, body aches, and headaches. And the fevers were cyclical, so they were every 48 hours she was getting a big spiking fever, and then in between she felt pretty well and didn't think too much of it. She was pretty sure this was not malaria because the prior episodes had been so much worse. But when we took a look at her peripheral blood smear, again, we're seeing some infected cells. This time, not just with rings, but some of these abnormal shaped cells that are not very typical for Plasmodium falciparum. All right, so this kind of bag of parasites here is a schizont, and that's about to rupture open and let out many of these parasites to infect other cells. When we looked around, we could also see that her infected cells were a little bit larger than the non-infected cells, and some of them had little finger-like projections called fimbriae. And all of these were clues that we were dealing with some non-falciparum type of malaria. So she, in fact, had a Plasmodium ovale infection. And ovale is interesting because it tends to have this recurring relapsing ability. And that comes from its hypnozoite. So to just take you back for a second on the whole malaria story, I just would like to review that life cycle so we understand all the events that have just happened for those two patients. So all of them are transmitted by the Anopheles mosquito, all of the species. And the Anopheles, as I was saying, is a nighttime feeder. So takes a blood meal and injects sporozoites. Those sporozoites travel to the liver in all of the different species of malaria. And they're silently replicating. So this is an asymptomatic period. And when we're thinking about those incubation periods, that can be a week or even 10 days before anything really comes up in terms of symptoms for the patient. Typically, the moment when the merozoite enters the red cell and begins to replicate inside of that red cell and then ruptures out. That's usually when those cyclical fevers are starting to happen. So our prophylactic medicines against malaria are typically acting at the level of the erythrocytic schizont. We're trying to prevent its from becoming symptomatic, but they don't actually prevent infection. So some people who take prophylactic medications can still get a version of relapsing malaria because the dormant form that stays in the liver, in the case of Plasmodium vivax or ovale, can later start to become symptomatic. So those are important concepts to think about when we're evaluating return travelers, because certainly with falciparum, if we recognize this early, we can certainly prevent a potentially fatal infection. Just to show you an example of how prophylaxis can fail, this is a young woman who had spent some time in Kenya and Uganda for her honeymoon. And she came to our emergency room with fever to 104 every 48 hours, chills, sweats, vomiting, and neck pain. So, the symptoms that are very consistent with malaria, but her travel to the affected area was many, many months before she presented. And so our emergency room was thinking, this is probably not anything related, and they were thinking more about our influenza season that we were going through. So she kept being diagnosed with either a viral gastroenteritis, given IV fluids and being discharged, and came back another time and was told she had the flu. But finally, one of our emergency room physicians ordered a peripheral blood smear. And that's the thing about our diagnostic tests in the United States. We have automated machines that count cells. They tell us the platelet count and the red cells and the white cell count. But they're not very good at looking inside the red cells. And it's inside the red cells that we're going to find these typical ring forms of the malaria parasites. So she, in fact, was presenting with malaria. She had a form that looked like a non-falciparum. A lot of these cells were kind of larger than the non-infected cells, and that's a helpful clue for non-falciparum malaria. When we looked around, we could see, again, some of these gametocytes and schizonts that are usually kind of tucked away when we're dealing with falciparum malaria and have a different appearance when it's falciparum. So she was treated initially for malaria. Because she looked kind of sick, they gave her treatment for falciparum malaria, then switched to chloroquine, which should be effective. But then she started to develop a severe left upper quadrant pain and a very significant drop in her hemoglobin. And what had happened is that her spleen had spontaneously ruptured. So she had this intense enlargement of the spleen. Again, the spleen is an organ that really filters out all of those infected cells and is a part of our immune response. But enlarged so quickly that she had a spontaneous hemorrhage. And you can see this area on her CAT scan that really highlighted that event. Fortunately, she just needed some blood transfusions and a few days in the ICU, did not require a splenectomy or anything dramatic like that. But it was kind of an interesting manifestation of malaria that we don't often see. So this was actually another case of Plasmodium ovale. And even though she had taken mefloquine during her time in Africa, that was only interrupting the cycle at this point. It was not preventing the initial infection, and the Plasmodium parasite can leave behind a dormant hypnozoite that requires a separate antimalarial to treat it. So typically for antimalarials, there's many that are based on basically an herbal medicine that was initially recognized in Peru. So in Peru, it was known for a long time that cinchona bark could actually be a good treatment for fevers. And eventually the compound that was isolated from it was quinine. So we have several different chemical variants on it, chloroquine, mefloquine, primaquine, and all of them have different levels of activity on malaria. Atovaquone proguanil has been a big part of treatment and prevention as well. Doxycycline has activity usually used in combination with other antimalarials. And the artemisinin derivatives are very interesting because they are very important in the global effort to eradicate malaria as well. So artemisinin, and this is a very interesting slide in this past year because the Nobel Prize was awarded for the researchers in China who were able to isolate this compound from, again, an herbal source. It's combined typically with a second agent because artemisinids have a very short half-life, so they're very quick to eradicate malaria parasites, but they don't stay in the body very long, and typically combine them with something else like lumefantrine to try to decrease the problem of resistance. And unfortunately, that the statement about no resistance reported to date is no longer true. We are starting to see some concerning signs of resistance to artemisinids. So for treatment of malaria, things can get very intricate and complicated, even though this slide is called uncomplicated malaria. So it's referring to the fact that this is the protocol we usually use for patients who are able to tolerate oral medications. They're not showing signs of organ damage. They don't have very high levels of the parasite in their blood. And we have several options depending on whether they're returning from a chloroquine-resistant area, where we might be dealing with falciparum, or areas of the world where they're either not infected with falciparum or there's a few areas left in Central America where chloroquine is still effective against falciparum. So this is typically a table we refer to from our Center for Disease Control. The severe malaria guidelines are usually going to use an intravenous agent in combination with a second agent. And the availability in the United States of artesunate is limited, so we have a supply that's with our Center for Disease Control, but it's typically something we have to get through investigational new drug approval and a lot of paperwork. So often we're still using a very old-fashioned intravenous quinidine because we don't actually have intravenous quinine in the United States. So it's a very unfortunate situation because this is typically a scenario where you want to get patients treatment as quickly as possible. And we're hoping that some of the FDA approval process for intravenous artesunate will be a little bit faster. Just a couple more cases to think about when we're thinking about return travelers with fever. So this was a 20-year-old man who presented with profuse vomiting and diarrhea, some chills, rigors, headache, and fever. And the onset of his symptoms was about a week after his 1-month stay in Jakarta. He was originally from Indonesia, but was living in the United States since he was around 6 years old. On physical exam, he had a very high fever, 105.6 Fahrenheit. Didn't show any signs of hypotension. On his physical exam, we did note a little bit of enlarged liver and a few mosquito bites on the extremities. He had lab abnormalities that were mainly significant for a bit of hyponatremia, but also some elevated liver enzymes suggesting some liver inflammation there with an elevated LDH. And put a picture of the street vendor here because he had eaten some food from street vendors while he was in Jakarta. And he was in our category of travelers that we call VFRs, or visiting friends and relatives, who are typically going to take a few less precautions in terms of preventing foodborne illness. So his blood culture started to grow a gram-negative bacillus, so shown here. It's typically an enteric pathogen that we can't really distinguish from many other gram-negative bacilli, such as E. coli or Klebsiella. But it started to grow on the plate, and we could incubate it on this triple sugar and iron slant that really told us that we were dealing with a salmonella. All right, so this is Salmonella typhi, the cause of typhoid fever. Typhoid fever in the United States is almost exclusively among return travelers. We certainly see plenty of non-typhoidal Salmonella gastroenteritis, but typhoidal strains are typically acquired after travel to developing countries. So we had around 5,700 cases in the U.S. per year, but internationally this is affecting about over 20 million people. So still a major issue and a potentially fatal infection as it disseminates through the bloodstream. So we do have some vaccines against typhoid. For some of our travelers, we're opting for the injectable form. It's an inactivated typhoid vaccine that's conferring around 2 to 3 years of immunity and not fully protective. So it's important that we still educate them about food and water precautions. The oral typhoid vaccine is one that's available for travelers who are not immunocompromised. So that's a live attenuated bacteria. And some people have some side effects with upset stomach, but overall I would say it's fairly well tolerated and does confer a little bit longer lasting immunity, probably around 5 years. In the United States, there's a lot of issues with preventative medicine coverage from our varied insurance policies. So I'm a great admirer of the National Health Service here because I think it simplifies things a lot and ensures everybody has coverage. But there we're faced with a lot of travelers having to pay for their vaccines out of pocket for a lot of these things. So here are some of the vaccines we do think about for travelers who are going abroad, and the ones in red are just the live attenuated virus ones. And coming back to the Zika topic, flaviviruses are named that way because of their association with jaundice. And the prototypical one was yellow fever. So yellow fever was a very important virus throughout the world. And in the history of the construction of the Panama Canal, it was one of the major roadblocks to completing that project. And Dr. Gorgas was one of the physician scientists who was there studying yellow fever prevention. And so a lot of his work led to the understanding that it was a mosquito-borne infection. Eventually, we developed a live attenuated virus vaccine that's very effective. It's a concern for our older travelers above 60 because there have been cases of the virus from the vaccine actually causing disease, either as a brain infection or a severe liver infection. And most of those cases have been in people who are somehow immunocompromised. So we're trying to avoid this vaccine in those who are either on immunosuppressive medicines for organ transplant. Increasingly, we see a lot of inflammatory bowel disease treated with inhibitors of TNF. So that's at Mount Sinai, we're a big center for people with Crohn's disease, and a lot of those patients are traveling to places where they could be at risk for yellow fever. And we're generally avoiding the vaccine and just going with insect-borne insect precautions. But the complicating factor with the yellow fever vaccine is the fact that the antibodies to that vaccine are making it difficult for us to figure out exactly who has antibodies against Zika virus. Because flaviviruses tend to have overlapping cross-reactivity on serology. Those that have had dengue or yellow fever vaccination or chikungunya could have a false positive on IgM testing for Zika. There's something called a plaque reduction neutralization assay that's helping us to try to distinguish that. So for those that do test positive on antibodies for Zika, we can look for a fourfold increase in those antibodies over time, but we can also look to compare their plaque reduction compared to dengue virus and chikungunya. And that's important because, as I was mentioning, the PCR testing for Zika virus tends to be a very short-lived time in which it's sensitive. So probably the viremia is lasting about 7 days for most people. And finding a negative PCR is reassuring, but we may be missing some of those cases as well. But I also mentioned some other vaccines here. So hepatitis A and B are now pretty standard throughout the United States as pediatric vaccines, but in our older population, we're seeing a lot of folks that need to catch up that did not get those as a child. A couple of different versions of the typhoid vaccine. Meningococcal vaccination, in particular for travel to the central band of Africa where there's a meningitis belt, or for travel to the Hajj in Saudi Arabia. Those are major events where you have many people in close contact with potential risk for meningitis. Had some interesting outbreaks of serogroup B meningitis in the United States as well among our college campuses. Rabies vaccination is certainly something that we think about, especially for our long-term stay travelers or expatriates who are going to be staying for longer than 6 months because of potential transmission from dogs, cats, or even monkeys. Japanese encephalitis is more of a specific vaccine to parts of Southeast Asia, South Asia, another mosquito-borne virus. As I was saying, the polio issue has led to some concern among travelers. We are giving adult boosters to travelers to certain countries. And then there are some typical vaccinations that we like to make sure people are up to date with in terms of their tetanus, influenza, for certain travelers, pneumococcal, and their childhood illnesses like varicella and the measles, mumps, rubella. So that's a typical conversation that we'll have with someone who's going abroad for a trip. Put a couple examples of personal protection, since this has come up a lot with Zika virus prevention. So the mosquito nets that we typically use for Anopheles prevention, for malaria prevention, can be treated with permethrin. And that is a substance that's actually an insecticide. So the insecticide stays in the clothing and the nets for several washes and kills insects on contact. So that's a very helpful and effective step for both Anopheles mosquitoes as well as Aedes mosquitoes. Repellents have been in the news a lot in the United States as well, because we're looking for things that are proven efficacy. Typically 20 to 30% DEET-based repellents are probably the best studied, although we also have picaridin as an alternative for those who don't like DEET. Those have been studied for pregnant women, so for some of our travelers who are pregnant and can't avoid travel to Caribbean or South American countries, these are some of the steps that we are now taking. So the next thing I wanted to describe and think about was just some of the dermatologic conditions that come up for travelers, because with Zika virus, again, we're thinking a lot about rashes, and it turns out dermatologic conditions are a really important cause of seeking medical advice after travel. So this is a paper from the GeoSentinel network. They study return travelers in travel clinics throughout the world, huge numbers of patients, and in terms of the overall reason for seeking medical advice, skin conditions was number 3, so it's a common issue. So just go through a couple more cases here of what kind of things that we might see. So this is a 57-year-old woman who returned from a 10-day trip to South Africa and Zimbabwe with a skin lesion on the back of her knee. She had visited a game park, and in order to get to the outhouse, she had to get through some pretty dense shrubbery. When she returned, she had some decreased energy, and by Friday, she was having fever and chills. She was not taking malaria prophylaxis for this trip, and didn't have any other skin lesions, and had not been in any fresh water. So this is kind of a necrotic center here to a skin lesion that's very much associated with this particular illness. It's called a tache noire, and this is associated with African tick bite fever. So African tick bite fever is another emerging zoonotic infection that we'll see in parts of southern Africa. In the Mediterranean basin, there's a version of rickettsial illness that's very similar. So they typically do present with that eschar, that scar, the necrotic lesion at the site of the bite, because that's the inoculation point for a lot of these bacteria. So rickettsial bacteria like to infect endothelial tissue, the kind of blood vessel cells, and as they do, they cut off the blood supply to the skin and give us that black necrotic spot. There can be a disseminated rash, and some people will miss the little eschar, and so that's why it's on the list for alternatives to in the differential diagnosis for Zika virus infection as well. In the United States, we have a version of this illness called Rocky Mountain Spotted Fever. It's Rickettsia rickettsii, and that can be much more severe. This one tends to be less so, and usually will get better even on its own, but most of these rickettsial pathogens will respond to doxycycline, and most of our prevention measures are with insect precautions. A couple more cases just to show you what these eschars can look like. This is actually one of our, this was a filmmaker who was in the northeast corner of South Africa, again with fevers, body aches, and inguinal lymphadenitis and a severe headache. This was the eschar that had kind of been unroofed. And then we had one of our residents, one of our physicians who had spent some time in Swaziland, who returned after 4 weeks there with fever, malaise, and severe generalized muscle aches with that eschar as well. In New York, we don't see very much Rocky Mountain Spotted Fever, but we do have a rickettsial pathogen that causes a disease called Rickettsialpox. And it's typically associated with mouse exposure. This is a tiny little eschar that's shown on this thigh that's transmitted by a mite that's present on mice. So we don't even have to have campers or people who are out there getting tick bites, where sometimes there are urban exposures to mice as well. So this was actually first described in New York City in 1946, and became a very important thing to recognize as well during our anthrax attacks. In 2001, we were seeing a lot of patients with eschars where there was concern about the possibility of anthrax. Since cutaneous anthrax can give you a similar presentation, we started to recognize more and more Rickettsialpox in New York City. Okay, and then sometimes travelers present with something like this. This is someone who was in Belize in Central America with a lesion on the back of the knee. And he had been on something called the ATM Adventure Trail. And we had a group of medical students from Mount Sinai who had gone to Belize and had been on this trail. So it involved going through some rivers. They went through some pretty dense jungle, used the machete to get through this path. And then they go to some caves that are underwater and visit some Mayan ruins. So it's a very adventurous trip, and they got to see some very interesting things. Fortunately, this was not one of our students who came back with this, but it did remind me of a skin lesion I had seen in Peru during this tropical medicine course, where we had again, almost looking like a necrotic spot, but this is actually a breathing hole. All right, and that breathing hole is for something that's just below the surface. This was a woman who had been in the jungles of Peru, and if you occlude that breathing hole, then what emerges is the larva of the botfly. All right. This is a terrible slide to show before lunch. I'm sorry for this one. But this is Dermatobia hominis. This is a fly that actually captures a mosquito in flight, and then the mosquito takes a blood meal and deposits the larva, which burrows under the skin. This is kind of the breathing hole apparatus at the top part of the larva. If you occlude it, then it will emerge eventually. In our traveler, it was not coming out of the way, so we had an excisional biopsy, and this is what it looks like on cross-section. Typically not associated with any kind of infections other than maybe a localized cellulitis, but helpful to recognize so you know the appropriate treatment. Okay, and then I'll finish up with a few cases from Central America. We've had many travelers going to Costa Rica. This is one of them. He's a veterinarian who spent a week in Costa Rica doing some river rafting and spending time in jungle lodges. When he returned, he noticed some lesions on his left wrist that he thought were spider bites. They weren't getting better, and then he started to notice a few more on his flanks and on the lower extremities. So because he's a veterinarian, he could also palpate the nodules that were kind of proximal to the lesion and realized that there were probably some lymph nodes that were enlarging. So when he came in, this is what the skin lesions looked like. You can see these ulcers have a kind of inflammatory base and then a fairly raised erythematous border to them. Okay, and as we looked at the other lesions around them, we could kind of see a few little satellite lesions surrounding them. Okay, so when we scraped the center of the wrist lesions, we just took a small 19-gauge needle to take a little sample and stain it with right Giemsa. What you can see are the human red cells and a human white cell with its nucleus and cytoplasm. And then inside the cytoplasm, you can actually see these parasitic cells with their own nucleus and a tiny little bar-like structure there called a kinetoplast. Okay, so this was an example of leishmaniasis that was acquired in Central America. And leishmania is another one of these vector-borne parasites transmitted by a tiny insect called the sandfly. So many people don't actually realize they've been bitten. The sandfly is going to transmit a form called the promastigote that will eventually cause an infection inside of our own immune cells. So our macrophages and local tissue cleanup cells are basically getting infected. There, the parasite goes through a transformative process called to become an amastigote. And when it ruptures out, there is finally an inflammatory response, and we start to see some of these cutaneous ulcers. So with leishmania, you can see a very big spectrum of clinical illness. This return trial, this was our veterinarian who had the cutaneous lesions. He was actually treated with a medication that recently had FDA approval in the United States called miltefosine. And miltefosine is nice because it's an oral medication that has fairly few side effects, and depending on the species, has a very good outcome. Here was another traveler who'd been to Costa Rica. He had an initial skin lesion on the arm. It was very interesting because he was a computer programmer, but his wife was an epidemiologist, so they kept very close track of how this all developed. You know, it was very, very nice of them to really have a time point there. But you can see this can enlarge. You can sometimes have not just an ulcer, but kind of a scabbed appearance, a bit of a dried appearance. When we again scraped underneath that, we can find the amastigotes of leishmania. Confirming the species on this is important. So what we typically do is we'll do this smear in our own lab, but then we'll send some samples to our Center for Disease Control because they're able to culture it and do direct PCR off of tissue or scrapings. So these particular cases that I'm showing you are all Leishmania panamensis, and this was a traveler who had actually been to Panama and returned with this very large ulcer on the back of his calf, And you can sort of see that proximal lesion here, the enlarging lymph node. So these organisms can spread. And his was confirmed as Leishmania panamensis. This was a woman who had one on the back of the earlobe that was just never getting better. She was a hairdresser who initially thought this was someone had cut her ear by accident and was initially treated with antibacterial antibiotics. Eventually we did scrape off some of that and found the Leishmania parasites. And the species identification can be very important because there are different clinical manifestations of Leishmania parasites depending on the species and region present. So cutaneous leishmaniasis, where it's just in the skin, will occur typically with Mexicana and Tropica. But with Leishmania panamensis and brasiliensis, you can actually later see a destructive lesion in the oropharynx and nose called mucocutaneous leishmaniasis. So we want to identify those patients and be a little bit more aggressive about treatment there. Visceral leishmaniasis here, Leishmania donovani with this major hepatomegaly, is something that is not seen as often in the Western Hemisphere, but certainly here you're seeing cases in Southern Europe, parts of India, and Africa. This is a very interesting clinical spectrum of disease with Leishmania because some patients tend to have a very intense cell-mediated immunity and delayed type hypersensitivity, and they typically, in about 30% of cutaneous leishmaniasis, will get better without any treatment. So that's reassuring. But then we have another spectrum of disease burden where you're seeing very high levels of the parasite burden with very poor immune response. And trying to understand that spectrum is one that may explain some of the reasons we see such differing clinical pictures. So as mentioned, the diagnosis of leishmaniasis, we're typically doing scrapings of the lesions. We can do right-Giemsa stain in our local labs. We can do skin biopsies that will show the parasites. There are culture methods for this, as well as direct PCR and isoenzyme analysis. So they're all available through our reference centers in the United States. But that differentiation is important when we're thinking about treatment because some of the treatments can be very toxic. So as I mentioned, 30% of these cases will get better on their own, but there are some cases where we're going to be using intravenous agents such as antimony. And antimony has a lot of side effects. It typically can cause myalgias, electrolyte disturbances, and even cardiac dysrhythmias. We are starting to see some activity of ambisome, amphotericin B in its liposomal form in particular, has been studied in visceral leishmaniasis. So we're using that in some cases of cutaneous disease because usually we can give a shorter course of that than with antimony. And as I mentioned, miltefosine is an exciting development as well. Just some examples. This was the computer programmer who was treated with amphotericin B, had sometimes some intensification of the inflammation initially, but then eventually had a scar that healed up fairly well. This was the birdwatcher in Panama who was also treated with amphotericin, and the person who had been in Ecuador as well. The amphotericin is it's not a benign drug. It has a fair amount of side effects in terms of nephrotoxicity and infusional reactions. But there's been some interesting studies in the Bihar province of India where they're actually treating with single doses of amphotericin and getting good responses with visceral leishmaniasis. So these are some of the examples of use of miltefosine. This is a Bolivian man in a study in physicians from Colombia who were using this oral medication for about a 4-week course and seeing some excellent responses. So that's encouraging because typically this is occurring in places where people don't have ready access to intravenous medications or the ability to monitor for toxicity of those medications. So we're hopeful that miltefosine will start to have a bigger foothold in Leishmania management. And this again was our traveler who had gone to Costa Rica. He was able to get miltefosine in the U.S. before it was approved by the FDA through an investigational new drug protocol, and it worked out well as well. Just show this one last case because it was an interesting one. We sort of see the overlap of tropical medicine and transplant. So this was a 53-year-old man from El Salvador, history of heart transplant a couple months before presenting with this skin lesion on his lower extremity. Had some painful nodules behind the leg as well, and pretty high fevers, wasn't responding to intravenous antibiotics against bacteria. So we did a skin biopsy, and on the biopsy, the dermatopathologist was saying, I think there's a kinetoplast here. Could he have leishmania? And we said, well, he's from an area that's endemic, and it would be weird because he had traveled for a long time because of his heart failure. But when we sent off PCR and serology, we realized this was actually a case of Chagas disease, reactivating in the lower extremity. Now, Chagas is transmitted by an insect called the reduvid bug or kissing bug, and typically this will drop down in somebody's when they're sleeping and take a blood meal, deposit the feces, adding insult to injury, and then they'll get this disseminated trypanosome in their body that can cause an acute illness, but more problematically will cause a chronic illness in which, in particular, muscle tissue is involved. So this was the patient who ended up being treated with 8 weeks of benznidazole, which is an antiparasitic we use for Chagas disease, and he had a very good outcome. And when we thought about it, we realized what his idiopathic cardiomyopathy was, in fact, Chagas cardiomyopathy. So now all of our patients from Central and South America before heart transplant are screened with Trypanosoma cruzi serology. So it's just something we need to be aware of in that population as well. So I talked a lot about different types of infections in tropical medicine, and these are just some of the vectors that we're thinking about, in particular now with Zika virus and Aedes aegypti and Aedes albopictus. But with leishmania, we have to think about the sandfly, with Chagas disease, the kissing or reduvid bug. The African form of trypanosomiasis is via the tsetse fly. Malaria with the Anopheles mosquito and understanding its biology becomes very important when we want to prevent its transmission. Babesiosis is a local infection we have in the United States, but also in parts of Europe, transmitted by the same ticks that transmit borreliosis or Lyme disease. So it's an important disease for us to recognize, in particular in the northeastern part of the U.S. Filariasis and a lot of these diseases on the brink. Again, another Nobel Prize this year awarded for ivermectin, trying to control some of these microfilaria transmitted by various mosquitoes, and the black fly that transmits river blindness as well. So I think that's actually a good place to stop, and I'll certainly thank you for all your attention. Very great pleasure for me to be with you here today, and we'll take some time for questions as well.